Hemorrhagic disorders and laboratory assessment. So just a brief overview of hemorrhagic disorders. So hemorrhagic disorders refer to conditions characterized by abnormal bleeding due to defects in the hemostatic system. These can be classified based on location, so are they local or generalized, types of bleeding, so mucocutaneous or anatomic, and the cause, are they acquired or congenital. So local versus generalized bleeding. So local bleeding is confined to a specific site or area. This is usually due to injury or trauma, infection, or tumors. This usually suggests a local vascular or tissue cause rather than a systemic hemostatic defect. Then we have generalized bleeding. This is bleeding at multiple or spontaneous sites. This indicates a systemic problem with hemostasis. This can suggest underlying hematologic or vascular abnormalities. For mucocutaneous versus anatomic bleeding, so mucocutaneous bleeding affects skin and mucous membranes like your gums, your nose, GI tract, and even the uterus. Some typical signs can be petechiae, ecchymosis, epistaxis in heavy periods, or even gum bleeding. This is usually associated with platelet disorders like thrombocytopenia, platelet function defects, von Willebrand disease, and certain vascular disorders like Ehlers-Danlos syndrome. For anatomic bleeding or deep tissue bleeding, this affects muscles, joints, and deep soft tissues. This is less superficial than the mucocutaneous bleeding, and this can suggest defects in secondary hemostasis, which is where those clotting factor deficiencies start to come in. This is common in hemophilia A or B and acquired coagulation factor deficiencies. And then we have acquired versus congenital hemostatic disorders. So acquired disorders develop after birth, and this could be due to a variety of reasons, such as liver disease, vitamin K deficiency, disseminated intravascular coagulation or DIC, certain medications like anticoagulants or antiplatelets, autoimmune conditions as well, such as acquired hemophilia. And then we have the congenital disorders. This is present from birth due to inherited genetic defects. And this can be from hemophilia A, which is a factor 8 deficiency, hemophilia B, which is a factor 9 deficiency, von Willebrand disease, and it could also be from just rare factor deficiencies like a factor 11 deficiency. So in summary, local versus generalized will help differentiate mechanical versus systemic causes, whereas mucocutaneous and anatomic bleeding localizes the defect to primary platelet or secondary coagulation hemostasis. Acquired versus congenital will help guide further investigation and management, so helping understand bleeding patterns is pretty crucial for effective diagnosis and treatment. All right, so we have hemorrhagic disorders of liver disease. So liver disease is a common cause of acquired hemorrhagic disorders. The liver plays a central role in maintaining hemostasis through the production of clotting factors, anticoagulant proteins, and regulatory components of the coagulation and fibrinolytic system. So when liver function starts to deteriorate, bleeding complications can occur due to multiple hemostatic defects. For the procoagulant deficiency in liver disease, the liver synthesizes most of the clotting factors required for normal coagulation. In liver disease, there is a reduced synthesis of these procoagulant proteins, particularly factor 1 or fibrinogen, factor 2 prothrombin, and factors 5, 7, 9, and 10. Then we also have the vitamin K dependent factors, which are factor 2, 7, 9, and 10, and these are especially affected. So without sufficient clotting factors, the coagulation cascade cannot proceed normally, which would increase the risk of bleeding. For platelet abnormalities, we have thrombocytopenia. This is common in liver disease, and this is typically due to hyperspleninism from your portal hypertension, leading to platelets, where it kind of holds on, it doesn't let them go. Decreased production of thrombopoietin by the liver, and bone marrow suppression from chronic illness or even alcohol use. So a platelet count below 150,000 is considered thrombocytopenia and will contribute to mucocutaneous bleeding risk. For DIC, or disseminated intravascular coagulation, liver disease can trigger or exacerbate DIC, which is a serious condition characterized by widespread clotting and bleeding. These mechanisms include a reduced synthesis of natural anticoagulants such as antithrombin, protein C, and protein S, It also has some things where it releases the activated procoagulants from damaged or necrotic liver cells, and also impaired clearance of activated clotting factors due to the liver's dysfunction. This imbalance leads to excessive clot formation, followed by consumption of clotting factors, which results in bleeding. Then we have hemostasis, laboratory test, and liver disease. So there are several lab tests that are used to assess bleeding risk and guide the management. First one is the prothrombin time, or a PT. This is often prolonged due to a decrease in factor 7. We also can do a PTT, or a partial thromboplastin time. This may be prolonged depending on the extent of the factor deficiency. We can also do a thrombin time, or a TT, which evaluates the conversion of fibrinogen to fibrin. We can also do a fibrinogen concentration, and this can be low in severe liver disease. Platelet counts, these will help assess the risk of mucocutaneous bleeding. And then also that D-dimer test, so it will be elevated in cases with increased fibrinolysis or even during DIC. Some factor assays we can do for diagnosis would be factor 5 and factor 7 levels. These are particularly useful in trying to differentiate liver disease from vitamin K deficiency. So in liver disease, both factor 5 and 7 are going to be decreased, but in vitamin K deficiency, factor 7 is low, but factor 5 will actually remain normal. For treatment in this liver disease, so we'll try to manage the bleeding in liver disease, which requires addressing multiple defects. So we could do some vitamin K supplementation if that's, we are suspecting deficiency. We can do some fresh frozen plasma, or FFP, to replace multiple clotting factors. Platelet transfusion in significant thrombocytopenia or during active bleeding. Can also give the patient cryoprecipitate for low fibrinogen levels. Can also do antifibrinolytic agents in cases of hyperfibrinolysis. Can also give recombinant factor concentrates in select settings to help with the patient as well. And then we would also try to treat the underlying liver disease and any triggering factors such as infection. So, just in summary, liver disease causes complex hemostatic disturbances involving clotting factors, platelets, and natural anticoagulants. Laboratory evaluation is essential for distinguishing liver-related coagulopathy from other causes like vitamin K deficiency. Treatment should be targeted to the specific deficiencies and guided by bleeding risk in clinical context. For chronic renal failure and hemorrhagic disorders, so patients with a chronic renal failure are at increased risk of bleeding due to platelet dysfunction and other hematologic abnormalities. Hemorrhage complications and chronic renal failure are typically mucocutaneous and are not caused by a coagulation factor deficiency, but are uremia-induced platelet dysfunction. For laboratory features, we would have a coagulation screening test. These are often normal. So your PT, PTT, again, those are normal. Bleeding time may be prolonged, but it's pretty unreliable, and this test really isn't used much anymore. Thrombocytopenia may be present, but it's often pretty mild. Anemia is common and can exacerbate bleeding tendencies by reducing those platelet functions. So the mechanism of bleeding in chronic renal failure. So the primary defect is platelet dysfunction due to the accumulation of uremic toxins, which can impair platelet adhesion, platelet aggregation, and interaction with the vessel wall. So anemia will worsen bleeding by reducing red cell support for platelet endothelial interactions. For management of bleeding and chronic renal failure, so they can do renal dialysis. This will help remove uremic toxins, and it will temporarily improve platelet function. You can also do a desmopressin acetate, which will stimulate release of von Willebrand factor, particularly that high molecular weight multimer. It improves platelet adhesion and reduces bleeding time. These patients need to avoid aspirin and NSAIDs, so these drugs can impair platelet function even further. Use of these medications in chronic renal failure can precipitate hemorrhage. Nephrotic syndrome and thrombosis risk. So in nephrotic syndrome, there is loss of low molecular weight proteins in the urine, including antithrombin, protein C, and protein S. These are natural anticoagulants, and their loss leads to a hypercoagulable state for the patient. Patients are at increased risk for venous thrombosis, such as a deep vein thrombosis or a DVT, renal vein thrombosis, and even a pulmonary embolism. So in summary, we have chronic renal failure leads to bleeding primarily due to platelet dysfunction, not coagulation factor deficiency. Laboratory tests may not actually reflect bleeding risk, so that's where the clinical context is going to come in very important. We can do dialysis and desmopressin. These are, tools that help for managing bleeding in chronic renal failure. And for nephrotic syndrome, this shifts the risk from bleeding to thrombosis due to urinary loss of those natural anticoagulants. For vitamin K deficiency, so vitamin K is essential for the synthesis of several clotting factors involved in secondary hemostasis. Deficiency leads to impaired blood coagulation and increased bleeding risk. Although rare in healthy adults, it is common in newborns, those with malabsorption, or individuals on restricted diets. So dietary requirements and sources. Vitamin K is found primarily in green leafy vegetables like spinach, kale, or broccoli. Our daily requirement is small, so dietary deficiency alone is pretty uncommon. The body stores vitamin K are pretty minimal, meaning that deficiency can develop quickly when the diet is interrupted, especially in patients on total parenteral nutrition without supplementation or individuals on fad or restrictive diets. For absorption and metabolism, vitamin K is fat soluble, which requires bile salts and intestinal absorption. Conditions impairing the absorption can include biliary tract obstruction, like a gallstone or a tumor, chronic diarrhea, or even malabsorption syndromes like celiac disease and cystic fibrosis. Antibiotic use may also reduce vitamin K levels by eliminating gut bacteria that help contribute to its synthesis. So hemorrhagic disease of the newborn. Newborns are particularly vulnerable to vitamin K deficiency due to they have sterile intestines at birth. There is no bacterial synthesis of vitamin K happening. And they also there's low vitamin K content in breast milk. So before the 1960s, hemorrhagic disease of the newborn was a common cause of bleeding in neonates, but now there is routine administration of vitamin K at birth, and this has dramatically reduced its incidence. So role of breastfeeding in prolonged deficiency. So exclusive breastfeeding can prolong vitamin K deficiency in infants because human milk contains low levels of vitamin K, and maternal antibodies passed to the infant may actually delay the development of intestinal flora. So without adequate gut flora or supplementation, vitamin K stores remain low, which increase the risk of bleeding for the infant. All right, so some clinical features of vitamin K deficiency. Some symptoms, they may have easy bruising, mucosal bleeding. They may have prolonged bleeding after an injury or surgery. And in severe cases, they may have intracranial hemorrhages, especially in the newborn. For diagnosis and laboratory findings, so for the PT test, this is the earliest and most sensitive indicator. The PTT may be prolonged in a severe deficiency, but otherwise it would be normal. Patients would also have a normal platelet count and bleeding time. Factor assays will show a decreased level of factor 2, 7, 9, and 10. Factor 5 levels will remain normal, which will help distinguish from liver disease, where factor 5 is also decreased. So in summary, vitamin K is essential for coagulation factor synthesis. Deficiency can lead to serious bleeding, particularly in newborns and those with fat malabsorption. PT is going to be the most sensitive lab test for this, and early recognition and supplementation are key to preventing hemorrhagic complications. So Coumadin and vitamin K antagonism. So Coumadin or warfarin is an oral anticoagulant that inhibits vitamin K dependent carboxylation of certain clotting factors. So specifically, it will interfere with the recycling of vitamin K epoxide back to its active form, which is necessary for gamma carboxylation of several coagulation proteins. So as a result, the liver produces inactive clotting factor precursors, which cannot participate in the coagulation cascade. The des-gamma carboxy proteins. So in warfarin therapy or vitamin K deficiency, the liver releases the des-gamma carboxy forms of factor 2, factor 7, factor 9, and factor 10, and this can also include proteins C, S, and Z. These incomplete proteins are known as the PIVKA or the PIVKA factors, which stand for proteins induced by vitamin K antagonist. So PIVKA proteins are non-functional, contributing to impaired coagulation and increased bleeding risk. So the detection of vitamin K deficiency for lab findings. So the PT is going to be the most sensitive indicator. It reflects decreased factor 7, which has the shortest half-life. PTT may be normal or prolonged in some severe cases, or prolonged deficiency. Normal platelet count and bleeding time. Again, we're going to have that decreased activity of factor 2, 9, and 10. Factor 5 will remain normal, which once again, I think we mentioned on the previous slide, this will help differentiate vitamin K deficiency from liver disease, because in liver disease, factor 5 is reduced, where in vitamin K deficiency, it remains normal. So the clinical relevance of warfarin monitoring or Coumadin monitoring, the dosing must be carefully adjusted and monitored to prevent excessive anticoagulation and bleeding, insufficient anticoagulation and thrombosis. So the INR is an international normalized ratio. We'll talk more about this in a different lecture, but this is used to standardize PT results across labs. So over anticoagulation due to warfarin or drug interactions can be reversed with vitamin K, depending on the severity. So in summary, the warfarin or Coumadin therapy will mimic vitamin K deficiency by producing inactive clotting factors. These are called PIVCA factors, which fail to support normal coagulation. PT is the key test, once again, for detecting both warfarin effect and natural vitamin K deficiency. And then recognition of the mechanism will help guide monitoring and treatment, especially in the anticoagulated or malnourished patients. For von Willebrand disease. So von Willebrand disease is the most common inherited bleeding disorder caused by a deficiency or dysfunction of von Willebrand factor. It may also be acquired in association with other diseases or conditions. Von Willebrand factor is essential for platelet adhesion and also acts as a carrier for factor 8, stabilizing it in circulation. Some disease associations, so acquired von Willebrand's disease. While von Willebrand's disease is often congenital, it can also occur in association with other non-genetic conditions leading to acquired forms of the disease. These include hypothyroidism, benign monoclonal gammopathies, Wilms tumor, intestinal angiodysplasia, congenital heart disease, pesticide exposure, chronic renal failure, lupus, other autoimmune disorders, can also be from lymphoproliferative disorders and also myeloproliferative disorders. For pathogenesis, so in congenital von Willebrand's disease, the pathogenesis involves decreased synthesis or defective structure of the von Willebrand factor. In acquired von Willebrand's disease, the mechanisms can include decreased production of von Willebrand factor, absorption of von Willebrand factor onto abnormal cell surfaces, removing it from circulation. So von Willebrand factor deficiency leads to impaired platelet adhesion at the sites of vascular injury, and the reduced levels of factor 8 further impair the coagulation. For clinical features, bleeding is typically mucocutaneous in nature, so they'll have easy bruising, nosebleeds, heavy periods, prolonged bleeding after dental work or even during minor surgery. The severity ranges from mild to severe, depending on the subtype and von Willebrand factor activity. For deep tissue bleeding, this is rare unless there is a coexisting factor 8 deficiency as well. For laboratory factors, the PT is normal, but the PTT is often prolonged, and that's because of the reduced factor 8 level, which is part of that, pathway. For bleeding time, it may be prolonged if it's even tested, and we can also do von Willebrand factor antigen and activity assays. Factor 8 levels as well, this is often mildly reduced. For treatment, they can do desmopressin. This is the first line in mild to moderate von Willebrand's disease, and it can stimulate endothelial release of von Willebrand factor and factor 8. You can also do antifibrinolytic agents, and this is useful in adjuncts for mucosal bleeding. These patients need to avoid aspirin and NSAIDs as they could worsen their platelet function. In summary, von Willebrand's disease can be congenital or acquired, with many systemic diseases associated with acquired forms. It primarily causes mucocutaneous bleeding due to defective platelet adhesion and low factor 8 levels. Once again, PT is normal, but PTT is often prolonged. The treatment can include desmopressin and other concentrates depending on severity and subtype. For the genetic basis of von Willebrand disease, So von Willebrand disease is caused by germline mutations in von Willebrand factor gene on chromosome 12. These mutations lead to quantitative or qualitative defects in the von Willebrand factor. There are different subtypes. So we have type 1, which is a partial quantitative deficiency of von Willebrand's factor. This is the most common. And then we have type 2, which has qualitative defects in von Willebrand factor function. And then type 3, which is virtually complete absence of von Willebrand factor. This one is pretty rare, but it is the most severe. For clinical features of von Willebrand's disease, it's really going to be your moderate to severe mucocutaneous bleeding. They'll also have other common presentations like easy bruising, nosebleeds, heavy menstrual bleeding, and bleeding after dental procedures or other minor injuries. They can have deep tissue or joint bleeding. This is rare and usually only seen in the type 3 or cases with concurrent factor 8 deficiency. Incidence in epidemiology. So von Willebrand's disease is the most common inherited bleeding disorder worldwide. Prevalence is estimated at around 1%, though many cases are mild and probably undiagnosed. Among women with the heavy periods, about 24% are actually found to have von Willebrand's disease. It affects both males and females, unlike hemophilia, which is X-linked. Function of von Willebrand factor. So von Willebrand factor plays a dual role in hemostasis. It's a carrier for factor 8, so it protects factor 8 from degradation and delivers factor 8 to the site of the vascular injury. And it also mediates platelet adhesion, so it binds to the subendothelial collagen at sites of vascular injury. And it also serves as a bridge between the collagen and platelet glycoprotein 1b receptor. This process is especially critical in areas of high shear stress, such as capillaries and the arterioles. For pathophysiology, von Willebrand's disease results in reduced platelet adhesion, leading to defective primary hemostasis. This impairment is especially evident in small vessels and high flow vascular beds. Consequently, patients experience mucocutaneous hemorrhage, which varies in severity based on von Willebrand factor levels, type and function of von Willebrand factor, and the presence of coexisting factor 8 deficiency. A definitive diagnosis of von Willebrand will require both clinical and laboratory criteria. So they'll take a look at personal and family history. Is there recurrent or unexplained mucocutaneous bleeding, family members with known bleeding tendencies, or diagnosed with von Willebrand's disease. For laboratory evidence of decreased von Willebrand factor, they would look at a low von Willebrand factor antigen or low von Willebrand factor activity. These may also include a reduced factor 8 level. They'll have an additional workup that'll aim to exclude other causes of bleeding and evaluate von Willebrand factor related defects. So we'll do a CBC, and this will help rule out thrombocytopenia. They'll do a PT, which is usually normal in von Willebrand disease, but it'll help rule out other clotting factor deficiencies like vitamin K related deficiencies. The PTT may be prolonged if factor 8 levels are significantly reduced. So that one could be normal, but it may be prolonged. There can also be some specialized von Willebrand factor assays. So you have your, like we mentioned earlier, von Willebrand factor antigen and activity. Same with your factor 8 activity. And we can also do a von Willebrand factor multimer analysis. And this is to help classify those subtypes from 1, 2, or 3. So pitfalls and diagnostic challenges in von Willebrand's disease. So diagnosing von Willebrand's disease can be complicated due to the physiological and genetic variability in the von Willebrand factor levels. So the genetic penetrance will vary among individuals and families. For the ABO blood group, individuals with blood group O naturally have lower von Willebrand factor levels to begin with. Hormonal factors such as estrogen increases, it can increase von Willebrand factor levels, so times of pregnancy or if someone is on oral contraceptives. Age, so von Willebrand factor actually increases with age. Inflammation and stress, these both can temporarily elevate von Willebrand levels, potentially masking the deficiency. These factors may lead to false negative results or variable severity in presentation. For treatment, this is going to be based on severity and subtype. If they have mild bleeding, we may just do some local measures like direct pressure, limb elevation, or even an ice pack. For moderate bleeding, they may take a desmopressin acetate, which would stimulate the release of von Willebrand factor and factor VIII from the endothelial storage sites. This is effective in type 1 and in some type 2 patients. You can also do estrogen therapy, and this is sometimes used in women with those heavy periods related to von Willebrand disease. If they have severe bleeding or surgery, we can do replacement therapy with von Willebrand factor containing concentrates. This would be mixtures of von Willebrand factor and factor VIII. And like mentioned, this is used in severe bleeding episodes if the patient's having major surgery or patients who are not responding to the desmopressin medication. Could also do some supportive and preventative care, so antifibrinolytic agents that would help with the mucosal bleeding. And once again, these patients need to avoid aspirin and NSAIDs, which would impair their platelet function. So, in summary, diagnosis of von Willebrand's disease requires clinical history and specialized lab testing. Lab interpretation can be complicated by blood type, age, stress, and hormonal status. Treatment is individualized, where mild cases may only need local care. Moderate cases can benefit from the desmopressin, and severe cases may need that von Willebrand factor VIII replacement. Hemophilia A, or factor VIII deficiency. So this is a hereditary bleeding disorder that is caused by a deficiency or dysfunction of factor VIII, which is the protein in the intrinsic pathway of the coagulation cascade. It leads to impaired secondary hemostasis and is associated with deep bleeding or anatomic bleeding. This occurs in approximately 1 in every 8,000 live births, and it almost exclusively affects males due to its X-linked recessive inheritance. Females are typically carriers, but symptomatic cases can occur in homozygous females, which is pretty rare, a skewed X chromosome inactivation, or in Turner syndrome where they have an X and an O chromosome. Genetics is caused by mutations on the F8 gene on the X chromosome, and it's inherited in an X-linked recessive pattern where males with the mutation are affected, and then females are usually asymptomatic carriers but could transmit the mutation to their offspring. Mutations may include inversions, which is the most common in severe cases, a point mutation, a deletion, or an insertion. For clinical features, they will have anatomic bleeding, which is kind of the hallmark of this. They can have bleeding into the joints, which is also most common. They can have muscle hematomas, prolonged bleeding after trauma or surgery. They could also have intracranial hemorrhages, and this can even be spontaneous in certain severe cases. So the severity will correlate with the factor VIII activity. So severe, luckily this is less than 1%. This is spontaneous bleeding. Moderate is 1 to 5%, and this is bleeding with minor trauma. And then mild is 5 to 40%, and this is bleeding with major trauma or surgery. Some complications they can have is musculoskeletal complications, so repeated joint bleeds can lead to chronic synovitis and joint deformities, and reduced mobility and arthropathy. Neurological complications can happen as well, where they could have intracranial bleeding or nerve compression from muscle hematomas. Psychosocial complications, so they can have depression, anxiety, and reduced quality of life. And they can also have a risk of drug dependency, particularly on the pain medication side. Inhibitor development, so up to 30% of severe cases will develop inhibitory antibodies against factor VIII, which makes treatment even more challenging. As far as the laboratory side goes, we would see a normal PT and a normal fibrinogen and thrombin time. Their PTT, though, is going to be prolonged, and this is due to the deficiency in the intrinsic pathway for factor VIII. We can do a factor VIII assay. This would actually confirm the diagnosis, and it would measure the degree of deficiency and help classify the severity. For treatment, they can give factor VIII concentrates. This is kind of the mainstay treatment right now. They can also give recombinant or plasma-derived concentrates, and this is used for on-demand bleeding episodes. Can be used for prophylaxis to prevent spontaneous bleeds, and it can also be used for, if someone's going in for surgery, to give before they go in. Other management options is the desmopressin. This is useful in mild hemophilia A and stimulates endogenous release of von Willebrand factor and factor VIII. Can also give antifibrinolytic agents, and these are used together with they're used for mucosal bleeding. Treatment of inhibitors, so bypassing agents immune tolerance induction therapy as well, supportive therapy, so if they have pain, we can manage the pain, physiotherapy, and psychological support as well. For summary, hemophilia A is an X-linked factor VIII deficiency affecting 1 in 8,000 males. It causes deep tissue bleeding, especially into joints and muscles. The PTT is prolonged while PT and fibrinogen are normal. It is treated primarily with factor VIII replacement therapy. Inhibitors may complicate treatment. And then we have hemophilia B, also known as Christmas disease or factor IX deficiency. So hemophilia B is a hereditary bleeding disorder caused by a deficiency or dysfunction of factor IX, which is a clotting protein that's essential for the intrinsic pathway of the coagulation cascade. It is clinically indistinguishable from hemophilia A, but it does require distinct diagnosis and therapeutic approaches. This accounts for approximately 14% of hemophilia cases in the United States, and it's estimated to occur in 1 in 25,000 male births. It affects males predominantly, and that's due once again to the X-linked recessive inheritance. As I mentioned earlier, it is also known as Christmas disease, and it is named after the first documented patient, not the holiday. Genetics, it is inherited in an X-linked recessive pattern, similar to hemophilia A, where males with mutation are affected and females are usually the carriers. This is caused by mutations in the F9 gene on the X chromosome, and it can involve point mutations, deletions, or insertions. For clinical features, they are clinically identical to hemophilia A with that anatomic bleeding. So they'll have that joint bleeding, muscle hematomas, post-traumatic or post-operative bleeding. They'll have risk of life-threatening bleeds such as the intracranial hemorrhages. And the severity is going to be based on the factor IX levels. So once again, severe, luckily it's less than 1%. It's frequent spontaneous bleeds, moderate 1 to 5% bleeding with minor trauma, and mild 5 to 40% bleeding with significant trauma or bleeding, or surgery, sorry. Laboratory features will have the the normal ones, your PT, PTT, fibrinogen, and thrombin time. These are all going to be normal. Take that back. Your PTT is going to be prolonged. Sorry about that. Everything else will be normal. Diagnosis can be confirmed by your factor IX activity assay. These levels will help determine severity and guide treatment. For treatment, they can give factor IX concentrates. These are primary therapy for all severities, and it's available as a recombinant or plasma-derived forms. It's used for on-demand treatment during bleeding episodes, for routine prophylaxis to help prevent joint damage and spontaneous bleeds, and also prior to surgery. Some other considerations: a long half-life of factor IX allows for less frequent dosing than factor VIII. So inhibitors like antibodies against factor IX are less common than in hemophilia A, but they can occur. So we may need to do some supportive care, which can include pain management, physical therapy, and multidisciplinary care for those joint and psychosocial issues. So in summary, hemophilia B is an X-linked disorder caused by factor IX deficiency. This accounts for about 14% of hemophilia cases in the United States. Clinical and lab features mimic hemophilia A with that prolonged PTT and normal PT. This can be treated with factor IX concentrates and with prophylaxis for severe disease. Hemophilia C, also known as Rosenthal syndrome or factor XI deficiency. So hemophilia C is a rare bleeding disorder. Approximately half of all reported cases occur in the Ashkenazi Jewish population, indicating a genetic predisposition in this group. Unlike hemophilia A and B, it affects both males and females equally because it has an autosomal inheritance. For clinical features, so there is bleeding tendency. It's usually mild to moderate. Bleeding often occurs after trauma or surgery, especially those dental procedures. Unlike hemophilia A and B, the severity of bleeding does not correlate well with your factor XI levels. Spontaneous bleeding with hemophilia C is less common than in hemophilia A or B. For laboratory features, you're going to have, once again, a prolonged PTT, and you're going to have a normal PT. So factor XI activity assay will confirm the diagnosis, and it may be identified during workup for unexpected bleeding or a prolonged PTT. For treatment, they can have frequent plasma infusions, so that fresh frozen plasma, and that will help replace deficient factor 11 before surgical procedures or during bleeding episodes. Factor 11 concentrates are also available in some countries, but they're less commonly used. Desmopressin is usually ineffective in hemophilia C, where they use it for A and B. Antifibrinolytic agents can also be used as an adjunct therapy for mucosal bleeding. So in summary, hemophilia C is a factor 11 deficiency with mild to moderate bleeding. This shows a poor correlation between factor levels and clinical severity. It's diagnosed by a prolonged PTT with normal PT, and it's managed mainly by plasma infusions before any invasive procedures. Some congenital or additional single factor deficiencies. So we have factor 5 deficiency. This is by definition a rare autosomal recessive disorder causing deficiency for factor 5. In clinical, it's mild to moderate bleeding, including mucosal bleeding and post-surgical hemorrhage. In the lab, they will once again have a prolonged PTT, but they will also have a prolonged PT with a normal bleeding time. For treatment, it can be fresh frozen plasma, as there are really no specific concentrates available. Factor 7 deficiency, this is the most common rare coagulation factor deficiency as it is autosomal recessive. For clinical, they'll have variable bleeding from mild to severe. Mucosal and joint bleeding are possible. They will have a prolonged PT, but a normal PTT. For treatment, it is recombinant factor 7A or plasma products. Factor 10 deficiency, this is a rare autosomal recessive deficiency of factor 10. In clinic, they would see a mild to severe bleeding. Spontaneous and traumatic bleeding can occur as well. In the lab, we would see a prolonged PT and PTT. For treatment, we'll have plasma or prothrombin complex concentrates. Factor 13 deficiency, this is a rare autosomal recessive disorder causing defective fibrin stabilization. They'll have a normal PT, PTT, bleeding from umbilical stump, poor wound healing, and intracranial hemorrhage can occur. For lab, they'll have normal routine coag test and diagnosis by the specific factor 13 assay or clot solubility test. For treatment, they can do factor 13 concentrate or plasma.